So, without any further ado, I would like to introduce to you our symposium chairman, who is well known to most of you, I'm sure. Dr. Dana Dupree is a retina specialist. He has his own practice called the Macular Center, located in Clearwater. You have a lot of information in front of you. They also have a table behind us. Dr. Dupree is a very accomplished in the field of retina and macula, and you will see from his bio, which is in your packet, he is a terrific doctor, a great friend of the Macular Degeneration Association, and a great presenter. It's now my privilege, and I ask you to give a hand to our chairman of our symposium, Dr. Dana Dupree.
Dr. Dupree.
Well, thank you very much, Larry. And Mr. Hoffheimer came to us, I don't know, about a year and a half ago, just with this concept that he had worked through Parkinson's, and he moved to Sarasota and retired, and I guess was bored with that or something. And with this connection to his mother who had macular degeneration, he developed this concept of delivering patient education direct to the patients. And that is what's unique about this group. And Dr. Tolentino and I and some of the other doctors, you know, basically came on board to do the first seminar, the second. Is this the third? Is this the third? About 7 altogether. Okay, great. So, you know, it's growing. It's basically designed to deliver to you in a very patient-friendly manner the state of the art. And we're going to start with the basics. We're going to talk about what is macular degeneration, a little eye anatomy, and then it's going to lead in through the day to, you know, more advances in treatments and, you know, current treatments and future treatments. So we're really happy to see all you people here. I recognize a lot of you. Dr. Tolentino's father is also with us, who is a professor in Boston, a retina specialist of tremendous respect. And I had the opportunity to work with him when I was doing research in Boston, so it's second generation, and it's really nice, the continuity that has come through that. So, as you know, I'm Dr. Dupree, and I'm a board-certified ophthalmologist and retina specialist. So, after ophthalmology, we do a residency where we learn to do the basics of cataract surgery, glaucoma, things like that. Then we spend another year or two in advanced training in retina. So that's pretty much our forte. As a rule, we don't go out and do cataract surgery and glaucoma surgery. Sometimes it crosses over into what we do. But our focus is just everything in the back of the eye, dealing with retinal detachments. Macular degeneration is, especially in the Florida area, is a large part of our practice. And trauma, things like that also usually come under the retina surgeons. We basically moved our building, which is right up the street. Well, we didn't move the building. We built the building, and we're right up the street, a couple miles across from East Countryside, and I'm not moving again. And I will be there until they drag me out, and I'm done. So whenever that is. But we're real happy to have everything under kind of one roof, and would welcome you to come by if you ever had any questions or you need further information in this area. Dr. Tolentino's practice has just been tremendous in the Lakeland area. The amount of research they brought into our area with many FDA studies and trials that him and his partners have been involved with. It's given me a great resource to refer to for certain patients, a lot of genetic problems and things which we're trying to get a handle on. So a lot of those things are going to be discussed through the day. As you know, there's many age-related eye conditions, and cataracts probably being the number one, and we have very successful surgery for that particular problem. Glaucoma, which is elevated eye pressures, or it can have normal eye pressures, but it's a resultant loss of the optic nerve fiber and health. High blood pressure can have effects on the retina, which in macular degeneration, as we're discussing, diabetic eye disease, dry eye, sounds like something that's not too serious but can be miserable. So we include that in some of these conditions. Macular degeneration as a rule kind of follows the aging curve because it's a breakdown in the pigment layer, just like we see little freckles on our skin. As our skin gets a little older, the macular pigment changes, and that weakens the central vision area in the back of the eye. We're going to go through that in a lot more detail. But things we look at is family history. We look for the pigmentation of the person. Fair complected people are much more likely to have this problem than dark complected people. So the early stages that we see with macular degeneration, what we're looking for is sometimes just a very subtle loss of acuity. Things aren't quite as sharp. Now remember, that could be a cataract, that could be dry eye. A dry eye can be a very blurry eye. So it's not always a macular problem, but those things have to be sorted out so you can address each of those problems individually. Anytime you saw any wavy distortion in your vision or a dark spot, not a floater, not something that's moving around, but something that's fixed in your central vision of a dark spot or a gray spot or a distortion, you know, you have to think that could be coming from the macula, the central vision area of the retina. Any kind of bent straight lines, you know, become wavy, door frames get a little wavy. Some people, everything's good on the vertical, but the horizontal's got a little blip in it. So those are things you can be looking for. We have new testing systems. The old Amsler grid has been the reliable little piece of graph paper, but it's fairly sensitive to detect changes, but now there's some devices far more sensitive. The advanced stages always affect the central vision area. There's mild macular degeneration cases, and then there's severe macular degeneration. And usually it's the size of the dark spot in the middle of the vision. There's almost always peripheral vision that's left, which is very, very functional vision. If you lost your peripheral vision and maintained 20/20 central vision, you'd probably be using a cane to get down the hall or a guide dog. When you lose your peripheral vision, you lose a lot of your ability to try to navigate around a room. We value our central vision for reading and driving, but for getting around a room and just basic ambulatory vision, that peripheral vision is extremely valuable. And a lot of times it gets looked at as kind of secondary vision, but that is not at risk as a rule, your peripheral vision in macular degeneration. That's kind of the good news, and we learn to function with that. But it's preservation of the central vision, which is our goal. The advanced stages, you know, the area, a lot of times it's the size of the central shadow, which we call the scotoma, which is just the shadow that's in your vision. And you have to think of it in terms of an arc. It's an angle. So a very small spot, I mean a pinhead spot on your macula, by the time you get out across the room, it projects a larger and larger shadow. So that's why if you get close to things, you shrink that scotoma and your overall vision seems to improve. You can't recognize a face across the room, but if they get up real close to you, you can start to make that person out better. Just like watching TV up close, you shrink the size of that dark spot. But you get back away from it and you might not see a bus down the street. So I just want you to think in terms, it's always to your advantage to move up and get closer to objects, which I'm sure you figured out. Some of the early symptoms we've kind of gone just a general blur, but contrast sensitivity, color vision changes, some of those can be cataracts, okay? But macula also affects that. So sometimes a combination of a cataract and early macular degeneration will get you to the point where colors are washed out, you have no definition. So cataract surgery may be something that we can do to help boost that, you know, the amount of light getting to your macula, the color wavelengths and so on can be of higher functioning on the macula if we get more of the blue wavelengths or some of these other things that get blocked out with a natural aging cataract. So the advanced systems, which we've kind of gone over, can get pretty bad, especially in that central vision. You're going to see through the day, though, how much better we're doing with wet macular degeneration, which used to be the one that just would take the vision down, and there wasn't a whole lot we could do about it, or anything we were doing about it didn't work very well. So it's interesting, over the last 7-8 years, we've been able to really manage the wet macular degeneration much better, and we're going to define all these terms as we go. But it kind of comes back to the dry macular degeneration is where we're really struggling to make some good advances. And those things are on the horizon and we will cover. I just want to give you a little idea of what it is we do when you come through the exam and why we're doing all those things. You know, we're asking you why you're there. That's always a good question because sometimes people are in my office that don't know why they're there, and I think that needs to be cleared up for the reason. We want to know if you've had any further eye surgery, anything that's been done on your eyes, try to get at any previous glaucoma history. Some of those things can be very subtle, so we're trying to kind of tease that information out and put the whole picture of your specific problem together. Family history is important. I mean, anytime I hear a family history of glaucoma, I want to really go over that patient and make sure that there is absolutely no signs of glaucoma, because that can rob the peripheral vision. So the combination of the two could be very devastating to your overall vision. However, if you aggressively manage glaucoma, especially in the early stages, you can stabilize that peripheral vision and not be at risk for losing that, especially combined with macular degeneration. They look at the vision. Obviously, you guys are all familiar with the eye chart. How well the pupils respond, it's a good indication of how the nervous system, if it's intact, just the little finger tests on your field of vision, making sure your peripheral vision's intact. Eye muscles, making sure there's no paralysis. Sometimes strokes and things can affect the eye muscles. Amsler grid, that little graph paper, because we want to make sure that all the lines are true and square and that you don't have any early signs of the distortion of those things. Eye pressure is very critical. It's 12 to 22 is a very normal range, although people can have significant glaucoma with normal eye pressure. So you can't ever think that glaucoma could be an entity just because the eye pressures are normal. So we look at the optic nerve, we decide if it's symmetrical, if there's loss of nerve fiber layer, and now we have very sophisticated scans that are very easy for the patient to do, which can actually quantify the amount of nerve fiber coming from the brain to the optic nerve, which then kind of splays out into the retina. Then we dilate, and you really, as annoying as it is, a dilated exam to really appreciate the whole inside of the eye is absolutely necessary. Otherwise, it's like looking through a keyhole and trying to describe this whole room to somebody. So a good full dilated exam is really mandatory. The visual test, the Snellen chart, is just those letters are based on ratios. And to kind of give you an idea, the 20/20 line, which is the second one from the bottom, the letters in the 2100 are 5 times bigger, okay? And if you look at the letters in the 2080, that's 4 times bigger than the 20/20 line. So those are just ratios that allow us to kind of quantify vision. It's not all there is to vision. Black and white letters in a dark room isn't how you see when you go outside and the sun's bright, or it's a dim lit day and your contrast ability is low, or maybe you have cataracts that aren't giving you very good light levels. So we understand there's a lot more to vision than just that chart, but it is well understood, it's standardized, it gives us a basic way to start talking about whether your vision's stable, it's improving, or you're losing it. The Amsler grid, also our technician will go over that with you, and we're just looking for any new changes in that graph paper or grid. We want you to do it very carefully. It's about 14 inches with your glasses on, focus on the center dot, takes a little practice, one eye at a time, and you're just seeing, is there any new changes on that grid? And if you've got the same old little spot, you can kind of pencil that in one eye, have one of the grids for each eye, or use different colored pencils, red for the right, and green for the left or something. But pencil in where those little distortions are. And then those should line up every time you check that grid. You don't have to do it every hour. You maybe don't have to do it every day, but you should do it maybe a couple times a week. Back and forth, right eye, left eye. Take you 30 seconds, but it's an early detection device. Any changes on the grid you should get in and be seen, okay? And we're going to go over some of the other testing devices. The eye anatomy is basically the eye is like a camera, okay? And the front part is the lens in the eye, and the retina in the back of the eye is like the film in the camera. And so if you have a blemish on your film, you're not going to get a sharp picture. And that's where people, sometimes they need to understand there's kind of two separate systems at work here. So the front of the eye, the lens, that's what gets cloudy, that's a cataract. We do cataract surgery, put a new plastic lens in, which is called the implant, and we can clear up that optical axis back to the macula. But if the macula has some problems to it, you're still not going to get a high quality, high definition picture. Some of the early anatomical changes in macular degeneration, the hallmark is these little yellow deposits called drusen, and they're kind of in the deeper layers under the retina, and we're going to go through that. We can loosely categorize these drusen as hard and soft. The hard are very well-defined, kind of glistening little round deposits. The soft are a little bit more creamy yellow and more diffuse borders, not well delineated. But the drusen happen down at that lower level. We're going to go through all these layers of the retina. The one on the top is the retinal layer, and then you see those little vertical lines. Those kind of represent the photoreceptors. And then there's another layer called Brooks membrane and the pigment cell layer. And all those layers basically combined form the macular imaging system of the eye. And the outer layer is the choroid, or very vascular layer. So what we're looking when we're looking at the back of your eye is see, how much of these changes you have. It can be very, very early. Sometimes they're not centralized. They can be off-center, which is much less visually a problem. We're looking for any bleeding, hemorrhaging. You could have a slight hemorrhage in your macula and never notice it. But if we pick up on it, you can treat that early and often prevent really severe problems from your central vision being lost. The difference between the wet and the dry is in the wet it's leaking, either blood or fluid, and in the dry it's more just kind of a breakdown in that pigment layer, kind of like these little freckles develop. But when we talk about wet, we're usually talking about some abnormal blood vessels that have broken through from the deep vascular layer. If you see that on the right of that little cube, the white, that's the white of your eye. So that's outside working to the inside. And so the eye's filled with that jelly structure called the vitreous, but the retina lines the inside of the eye like wallpaper, okay? And so when you get to that little cube and you go from the white outer sclera, you work into a vascular layer, then you have basically a membranous layer there, the pigment cells, and then you get to the actual retina with the photoreceptors, okay? And little blood vessels break through and get under the retina that shouldn't be there, and those bleed. That's wet macular degeneration. That's what these new drugs are so effective in shrinking that blood vessels back down and stabilizing that. That's a long time ago. Dark hair, a lot of things going on there. You got the slit lamp exam, the ophthalmoscopy, and the lens. Yeah, go ahead. So we're just going to kind of go over some of the instrumentation. That vertical slit lamp that's always coming at you, it's basically just a microscope. And it allows us to get a very highly magnified look at the back of your eye. It's a wonderful device. It was invented a long 100+ years ago. It's really changed very little. It's a very effective means for us to look at the detailed structure of your eye, from the cornea, from the front, all the way through your iris, your lens, and then back to the retina and the optic nerve. We have different lenses that we can place on the eye that allow us to visualize different structures in the eye. Some of these lenses even have little mirrors inside that help us get up into the very front. 10 minutes, So we're going to talk about that. So the very lenses we use, sometimes they actually, we put them on your eye with the gelatin substance. And this is all just so we can get a clearer, better picture of the inside of your eye. Dr. Tolentino and his group in Boston had a lot to do with the early development of a lot of the instrumentation, the different things that we use. Their group in practice really invented a lot of the imaging devices that we use on a regular basis now. That's the father. You don't get the credit for that. Okay. So we're basically looking at your vitreous. Well, we start in the front, the cornea, the iris, the health of the iris, the lens in the eye, whether you've had cataract surgery or not. Was it an easy surgery? Was there a little more trauma involved? Because those things involve some impact to the macula. We look at the gelatin structure. Is it clear? Is it cloudy? Does it have a little blood in it? Is it creating a lot of opacities in your vision, which could be visually annoying? Then we get into the retina, looking for the structural changes there. Fluorescein angiogram is a dye test that we've used now for probably 50 years. It's a very safe test. I mean, as an average, it's probably 1 in 17 or 1 in 18,000 chance of having a severe reaction to the dye. There can be some nausea, there can be some vomiting, maybe in the 1 in 100 range, and we can usually get around that with Benadryl. But this test gives us very nice detail of where these blood vessels are. Are they in your central vision area? Are they out of the central vision area? Could we possibly just laser and stabilize that to where you don't have to get these injections, which we'll cover later, on a monthly or bi-monthly basis? So the fluorescein angiogram is a commonly used test which allows us to kind of see how things are progressing. We may check it every few visits or so to kind of manage it better. And it's been the hallmark of a lot of retina decisions really over the decades. It does help us define some categorizations of wet macular degeneration. You can see here, does that play through again, Mark? Yeah, okay. So you kind of see on fluorescein angiogram, the way that you'll see the early dye leakage kind of coming into that active blood vessel membrane. And as we follow the sequence of the angiogram and we see more and more of that white dye, that indicates that it's actively leaking, okay? As opposed to staining, which may just be stable and not necessarily need treatment. And we define these different leaks by various things, classic and occult. That allows us to strategize what treatment we're going to use, which would be more effective. This large leakage that's throughout your whole central macular area, that's considered occult and creates a little different set of problems. There's little blisters in the back of the eye that come out, and those are in those deeper layers, little fluid pockets and collections. That helps us kind of decide what's the best approach for your macula. There's other conditions in the macula that are not macular degeneration, but they kind of behave that way, that create distortion. So we have to separate out and make sure that it is truly macular degeneration and not some other condition, and that's part of what we do. There's another dye that's used on occasion that actually kind of gets a deeper look. It's in the infrared, and it's a deeper look into where some of the leakage may be coming. And again, we may vary our strategy on how to treat that eye based on that. Then we came in the last 7-8 years with an amazing device. It's like a CAT scan of your retina. However, it doesn't require any radiation. It's a white light device, so you're not getting scanned with any kind of radiation, but it gives us an image that's like a CAT scan. And now we even have the ability to look at 3-dimensional images, but that's a slice right through your macula in that colored image. And it shows a breakthrough of some abnormal vessels. The drusins show up very nicely on that, little pockets of fluid. We can monitor the thickness. There's a little thin line on the top, which we'll show you another scan. This device has just been phenomenal in helping us really understand things that we were seeing before and thought we understood. This device has really allowed us to be very certain on where the problem lies. All these illustrations I was going to mention, that's all Mark's artwork. He's an ocular illustrator. I think he does a phenomenal job. illustrates for other companies really around the world. He's had about 50, 60, 70 magazine covers with his art and illustrations. So I just always have to thank Mark for his incredible work, because I think it's a lot on the patient education and the doctor education to describe what it is we're doing. So now we get a look in that. Go back to that illustration just for a second. So when we look in the eye, like on the top left, we see that white spot on the right is the optic nerve. Those are the normal blood vessels. And then that central white spot, that's a defect in the retina. Now we can scan through that, and that's what we'd see at the microscope on the top left, the big image. But now we can scan through that and actually understand what's going on in that area much better, and then start to direct our treatment to that. And, okay, again, here's another scan, and you get an idea of the layers of the retina, and then you get down to that little area that's kind of broke down. I forgot my pointer. Do you have a pointer there? No? I had one. Oh, there. Yeah, I'm using that pointer. Thank you, Larry. Nice job. So, I think you get the point. You guys that have been in the office, most of you have had the scan, and you realize it just takes under a minute, and the amount of information we gain from that. So we use this very frequently now. We do less angiograms, which is good for the patient because you have less dye and that type of thing, which can create some problems. But this scan is something we work with on our, almost every time we come in, we're kind of following the progress. Here is very interesting, and we see this not infrequently, where the jelly in the eye is pulling away on the macula. Now that would behave like macular degeneration, but that could either release itself spontaneously and all that swelling in the middle would come down, or we can surgically release that, and within a week to 10 days, the scan will start looking better in that patient, and that will get rid of the dark spot in the center of their vision. So that acts like macular degeneration, but that's not macular degeneration. And then here you can see on the right, 3 weeks later, all of a sudden we're seeing much improved contour of the macular surface, and the vision improves with that. This device came out a few years ago, and then it's gone and become the 4C home testing device. So this was an early detection, early change device that we were looking at using in our office. They've converted this technology now to become the most sensitive means of detecting early change in your maculas that's available. And that device is available today. They're in the back of the room. They're sponsors here. We're really, really appreciative. Yeah. Okay. Last slide. Thank you. My website, maculacenter.com, has most of this stuff on it. We work on it constantly. Mark does. I take some credit, but really don't deserve much. Mark works on it almost every day. So maculacenter.com can really fill out a lot of these information gaps, things like that, and you might like to follow up on. And you can Twitter us.